No promises. All right. Welcome everyone. It's good to see you. Couple of things. Just remember today is going to be a little bit of heavier content. So do what you need to take care of yourself. That means stepping out of the classroom, taking a minute for yourself, leaving early, whatever that is fine as long as you're taking care of yourself. I trust that you are the expert in your life, so you know what you need. Couple of things with that. I am doing a recording of this session for the folks who it was better for them to not be in person. So I have to stay up by my computer so that it picks up my audio really well. So I apologize that I'm not going to be walking around very often. And if you ask a question in the class, please do. You're just going to hear me repeat it because the people who are listening to the recording won't be able to hear the question. So I'm repeating it. So I apologize if I sound kind of annoying. Next Tuesday will be exam 2 over chapters 5, 6, and 7. Then we won't have class on Thursday. And then the week after that, the Thursday after fall break, is when your first biopsychosocial case conceptualization paper is due. Reach out if you have questions about it. I'm happy to answer them. Any questions before we jump into our conversation about chapter 7? Okay. So we'll just keep going. So when we left off on Tuesday, we were talking about some of the causes of both depressive disorders and bipolar related disorders. And there are multiple different influences or things that feed into a diagnosis in both of these categories of mood. One of them that comes up frequently that we've talked about before is that mood disorders, both depression and bipolar related disorders, tend to be related to low serotonin levels. But it's important to keep in mind that the serotonin is just one component of this influence. So just low serotonin by itself is not an automatic indicator of depression or bipolar disorder for anyone. It's when that low serotonin occurs with other symptoms. Because there are many folks who have low serotonin who do not meet the threshold for a diagnosis in either of these categories. We also have this thing called the permissive hypothesis, which relates to serotonin specifically. And it relates to it in saying that serotonin is the neurotransmitter that permits other transmitters to really disperse themselves amongst the synaptic gap. So when serotonin is in normal levels of what is expected to be normal levels, it allows other neurotransmitters like norepinephrine, dopamine, oxytocin, acetylcholine. It allows them to vary more widely across the entire system, the neurotransmitter systems. But when serotonin is in low volume, we don't get as much of those other variations. So the other neurotransmitters aren't permitted to act as often. We talk about the permissive hypothesis specifically in relation to dopamine and norepinephrine, because norepinephrine, if you remember back, is the neurotransmitter that calms the system down. It's an inhibitory neurotransmitter. And dopamine has to do with reward, feeling reward and pleasure. So if those are not being permitted to fire within the neurotransmitter systems, we're seeing less pleasure, less reward, and more activation overall. Also, we see that both depression-related and bipolar-related disorders are associated with sleep disturbance and excessive or elevated levels of cortisol. So cortisol is the stress hormone, is sort of how it's described It is the hormone that gets emitted when we are in high tense situations. This is the one that people talk about as like stress is going to kill your heart. It's because it's the excessive amounts of cortisol are causing damage to the body. And in regards to depression and bipolar related disorders, when cortisol is in elevated volumes, there's more cortisol. Our brain isn't able to engage in what we call neurogenesis, which, if you remember, neurogenesis is the formation of new neurons. So when we can't make new neurons, we can't change neural pathways. We use the same previous neural pathways that might be associated with depression or bipolar related disorders. Sleep disturbance as a whole is pretty much across the board a component of mood disorders. Like all depression related disorders, all bipolar related disorders have some symptom related to sleep disturbance, which leads us to believe that this is more of a universal system than it is specific to a diagnosis. But what we see uniquely on the backside, if we hook someone up who has a diagnosis of depression to an EEG where it maps their brain waves while they're sleeping, those individuals who have a diagnosed depressive disorder have quicker and more intense REM sleep stages. So less dreaming, but the dreams that do occur are high intensity. We're seeing a lot more of that firing within the brain during that REM sleep period. Yeah.
Is that like a good thing? Because like REM sleep is supposed to be positive, like good sleep. Like if they're having more intense but shorter periods, like how does that equate?
See, and that's the part that we don't exactly know about. So for those who are listening to the recording, the question is it a good thing that REM sleep is shorter and more intense because REM sleep is more positive, more restorative? We don't know exactly, but rather that they're correlated with one another. From an outside perspective, if there's less REM sleep, we're not getting as much of the benefit. And maybe that is part of why we don't have the abilities to regulate those moods. But because they're more intense from an outside, it seems like those should counteract. But we don't really know. I definitely don't know. But yeah, that's a great question. So this is the neurobiological components or influences on depression and bipolar related disorders. We also have psychological dimensions or influences primarily related to stress. Mood disorders as a whole are strongly related to stress. And they're related to stress in multiple areas. So we see that individuals who meet the threshold for a mood disorder that are in treatment, when they are then stressed on top of that, they tend to have what we call a poorer response to treatment. They're not as responsive. It takes longer for the treatment to work for them. So again, we're talking about already diagnosed and in treatment. Then when we add on the stress, poorer response to treatment. And that treatment taking longer before we reach what we call remission, which is where someone's symptoms have been below the threshold of a diagnosis long enough that we can say it's not active at this time. So think about with depression, major depressive disorder specifically, do you remember the length of time between depressive episodes for us to consider them separate episodes of major depression? Yeah, 2 months. So if someone goes 2 months and they don't have any more symptoms of a major depressive episode, like any symptoms at all, they're in full remission. If they have some symptoms of a major depressive episode, but they are below the threshold of a full major depressive episode, they're in partial remission in that 2 months time. So when we add stress on top of that, it takes much longer for folks to get to that remission stage, and it takes longer for the treatment to work. Stress influences us in so many ways, and it makes the diagnoses last much longer because all of the stats that we have that we've been talking about with depression and bipolar related disorders are directly related to if these symptoms are untreated, how long will they last? And stress almost puts someone at a level of being untreated, even if they're in treatment, because it slows things down. We also see a gene environment correlation with stress and these disorders. Specifically, folks who are vulnerable to depression might be more likely to enter into situations that will lead them to experiencing stress. So the vulnerability of the diagnosis makes someone more likely to create environments that add stress to their life, which then reinforces the depression. And it creates this cycle for folks. There's also a theory around depression that we call the learned helplessness theory. Have any of you ever heard about the learned helplessness theory before? Yeah, what stands out about it, if anything? Moss, do you remember anything? Yeah. Yes.
They didn't believe that they could do something, so then they like putting themselves in that mindset, and it's like a cycle.
Yes, perfect. Yeah, you're nailing the like overarching theme of it. We did learned helplessness studies with dogs specifically. The dogs were put in this like two-sided cage that has a little half wall in the middle, and they would harness the dogs on one side and they would shock the floor at random intervals and for random amounts of time. And the dog was harnessed so that they couldn't get away. And what they found was that the dogs developed what they called learned helplessness, where even if they disconnected the harness, the dogs would just sit there and take the shock because they had learned nothing that I do is going to stop the pain. Because even if they tried to get away, they couldn't get over the wall to get away from the shock because they had been harnessed in the first place. And they said that the dogs have this learned helplessness. I have to just take what is going on because there is no point in trying. It's not going to change anything. Learned helplessness was proposed, goodness, by Martin Seligman. He was the one who did the studies with the dogs. For those of you who are animal lovers like myself, the way that they changed the dogs and taught them away from learned helplessness was they actually had to show them by like lifting their front paws over the wall to the other side of the cage so that they would be shocked. And that was the only way that they could break the learned helplessness with the dogs. But it's this idea that we have a lack of control or perceived control over our life events. So we stop trying to change them. It feels like we are helpless to them. So why waste the energy trying? And it creates this cycle for folks where it's like, why try? It's not going to change anything. So I'm not going to keep trying. And then it's still not going to change anything. And that sort of leads into or gives us insight into the cognitive stressors for mood disorders or the cognitive theories for why mood disorders occur. And one of the theories, cognitive theories of why both depression and bipolar occur is what we call these negative coping styles, which is this idea that individuals who are in a depressed episode, whether that's related to a depression disorder or a bipolar disorder, they engage in these negative cognitive errors repeatedly that then inform their behaviors. So essentially, they have a tendency to interpret life events negatively, even though the event itself doesn't have a negative connotation. There are two types of negative coping styles that occur with depressive episodes. And again, both of these are interpreting our life environment as negative. The first of those is what we call an arbitrary inference, which is where we overemphasize negative aspects of mixed situations. So you're in a situation where there are both happy components and unhappy components, like, it's a terrible example, but like if you go to a funeral for someone who was very old, there's oftentimes, and like they were very sick at the end, there might be some happy components of like, oh, they're no longer in pain, they're no longer suffering, but there's also this sad component of we lost someone that we loved. It's a mixed situation. With an arbitrary inference, the individual would take all aspects of that mixed situation and interpret them as negative. The second type of negative coping style is an overgeneralization, which is where we apply negatives to all situations, even inherently positive situations. It's like an inherently positive situation. You get 100% on an exam in a class. An overgeneralization might be, yeah, but I'm going to fail all the rest of them, so I'm still going to fail the class. That would be an overgeneralization where we're applying negative coping styles or negative cognitive schemas to all situations, even if they are inherently positive. We also see depression being a component or being reinforced by what we call our attribution style or attributional style, which is how we attribute negative outcomes and events. So a negative event occurs or is present, how we source it, how we attribute that to occurring can influence our rates of depression, specifically by contributing to a sense of hopelessness. So hopelessness is one symptom of a major depressive disorder, and these attributional styles are said to be components of that hopelessness. So we can make internal attributions where we say that negative outcomes are our fault. Anything negative that happens in our world is our fault. My dog got hurt because I wasn't there to protect him. I failed an exam because I'm a terrible person. This negative attribution relating it to self. That's why it's internal. We also have what's called stable attributions, which are believing that future negative outcomes will be our fault. My relationship is going to fail because I'm a terrible person. My partner's not going to love me. Doesn't matter how well I do on these exams because I'm still going to fail and it's going to be my fault and I'm going to drop out of college. So we're looking, these stable ones are looking towards the future. And then we have global attributions, which is believing that negative events will disrupt many life activities. So my relationship fails. That means that I'm never going to graduate from college. I'm never going to get a job. I'm going to live at home with my parents forever. And I'm going to die before I turn 30. Like one negative event will lead to all of this disruption in someone's life. Global and stable attributions run into each other a lot. Like they overlap quite a bit. I'm giving you these examples just to give you an idea of what this attributional style looks like. But we also have what's called the depressed cognitive triad, which is a psychological component of depression. The cognitive triad was proposed by Aaron Beck, who's like a huge researcher in depression, the biggest proponent of cognitive theory, which is a type of treatment that we use for depression, the basis of cognitive behavioral therapy that we've talked about a couple of times. He proposed that individuals who are depressed have these 3 depressed cognitive beliefs that will influence their depression, like make it more intense or maintain it. And folks who have depression have negative thoughts about themselves. They negatively think about themselves almost consistently. They also have negative views of the world. and they have negative views of the future. So these are most deeply related to beliefs that the person has about themselves, about the world, about the future, that are oftentimes outside of their awareness. They don't know that they have these beliefs, but they're operating under the surface all the time. And the combination of them, again, maintains or sometimes strengthens symptoms of depression. Questions about the psychological influences of depression and mood disorders? Okay. We also have social or cultural dimensions of mood disorders, and these relate to the things that are going on in our environment that can influence our rates of diagnoses. One of those is actually marital satisfaction. Research has shown that marital dissatisfaction is strongly related to rates of depression. Interestingly, though, marital dissatisfaction predicting depression rates is different across assigned sex. Which assigned sex do you think is most strongly influenced by marital dissatisfaction? Any guesses? It is males. Yeah. We find that the rates of marital dissatisfaction leading to depression is stronger for males than those who are assigned female. And we also see that the dimensions of social support play a large factor in rates of depression as well. A lack of support is really predictive of depression when we're talking about late onset. So folks who are 65 and up, the less support they have, the more at risk they are for developing depression. And the inverse is also true. The more support someone has once they're in treatment, the more predictive of recovery. So reaching remission for their diagnosis. Support is a huge factor when it comes to depression and having an opportunity to chat with people. So we talk about social support as being particularly important in the context of folks who are 65 and older. Because remember, there are 2 times in someone's life when they are at most risk for developing depression. One of those is when they are young adults, and the other is when they're 65. Think about social support and around the time that you're 65. What's happening in your life to your social support? People are dying. Your social supports are dwindling. Your friends, your siblings, you may have children, but you may not have children. The environment that you're in as well, where you live, how closely you live to other people is changing rapidly. And that can alter social supports. So we've talked about the causes of these mood disorders. Let's take some time to talk about treatment because there are many different things that we can do to affect treatment outcomes for mood disorders as a whole. One of the most common treatments for depression is antidepressant medications. There are different classes of antidepressants. I don't want you to know what the differences between these are. I just want you to know the different types of classifications. SSRIs are those selective serotonin reuptake inhibitors that we talked about in chapter 2, where we are allowing serotonin to bounce within the synaptic gap much more frequently. Mixed reuptake inhibitors, which is the last one in this list, are the SNRIs or the SSNRIs, where we're allowing for more serotonin and more norepinephrine to be present. There are other types of antidepressants, including MAOIs or monoamine oxidase inhibitors and tricyclic antidepressants. Again, these are just different classifications of these medications that all target different neurotransmitters and in different ways. Why do you think antidepressant medications are one of the most common treatments for depression? You look like you had something to say, and it's okay if the answer is no. Yeah, perfect. That's awesome. That is one of the reasons why we see it, is that medication works typically much faster than therapy. So it's oftentimes prescribed as the first line of treatment while simultaneously starting therapy so that the therapy can work much longer term, but the medication can get the symptoms under control a little bit faster. Antidepressants are still not quick. These antidepressants that we're talking about take about 4 to 6 weeks for full functioning, like where they're fully operational for that person, because you need to have the medication built up in your system before it works properly. Another reason why antidepressants are really common is because of who prescribes them. If you remember back from chapter 1 or chapter 2, the first people that are oftentimes gone to for any mental health concern are primary care doctors. Primary care doctors can prescribe antidepressants because they're relatively safe. The side effects are relatively minimal compared to other more advanced depression medications. So they are oftentimes prescribed because we can use them as a bridge until we find what really works for someone. Across the board for all of these types of antidepressants, they're all about equally effective to one another. It's just finding which one works for that person and at which dose. It tends to be a little bit of a trial and error process for people to find which one works. About 50% of people who take antidepressants will experience some benefit from the medication, with about 25% of people reaching what they consider to be normal functioning for them. And that is true across all of the classes of antidepressants. Bipolar disorder is a little bit more narrow in terms of our medication options. The first line medication for bipolar related disorders is lithium carbonate, or just lithium as it's shortened. It is the treatment of choice because it treats both valences of mood. It treats both depression and mania, where antidepressants only treat the depression. In fact, for some individuals who have a bipolar related disorder, if you prescribe them an antidepressant, the antidepressant will actually send them into a manic episode or a hypomanic episode. It's not true for everyone who has a bipolar related diagnosis, but for some folks, an antidepressant alone will spark a manic episode or hypomanic episode, which is why lithium is the treatment of choice, because it treats both ends. Unfortunately, though, lithium has to be monitored very heavily because it is toxic in large amounts. Typically, folks who are on a lithium treatment are seeing their psychiatrist regularly, typically no more than 2 months between appointments, just to have it monitored. We need to make sure you're not experiencing any of the symptoms of toxicity because they can develop over time. When lithium is diagnosed, it's effective for about 50% of individuals, which is a good amount. That's a pretty high amount. There are some folks who don't respond to lithium, and in those cases, other medications such as anticonvulsants or anti-seizure medications and calcium channel blockers can be recommended, but they're also ones that have to be strictly monitored very carefully, frequently, and that's why we don't use them very often. But for some folks that don't respond to lithium, they are options. We also have some additional treatments for both depression and bipolar related disorders, but mostly for the depressive side of these diagnoses. And they include actually types of psychosurgery. One of those that is common for depression, not common, one of those that is present for depression, it's a very rarely used option, but it is used, is anti or electroconvulsive therapy, otherwise shortened to ECT. ECT is a rare treatment for folks who have severe medication-resistant depression. It is oftentimes considered a last option because it is more invasive and it works by temporarily or inducing temporary seizures for folks. They're brought in, they're put under a light sedation. I think they call it like twilight sleep, like whatever they put you on for when you get your wisdom teeth removed, that level. And they do that so that you don't harm yourself during the seizure. And they put a mouth guard in, and you're laying on your back, and they put these electrical little paddles on your temples, and they briefly shoot electricity through the paddles to induce a temporary seizure. And what we found is that after about 6 to 10 sessions of these ECT therapies, they start to experience significantly less depressive symptoms. We don't know why. We do not know the mechanism by which ECT works, besides that for some folks, when they have the seizure, it just rewires a little bit of their brain temporarily. The effects are not tremendously long lasting. They usually last a few months, like about 6 to 12 months, but then they have to go in for more sessions. There are side effects to ECT that are not favorable. Most often folks describe headaches, but the bigger problem is memory loss. They often lose the time leading up to the treatment. Some folks it's an hour, couple of hours, some it's up to a few days or a week or so. That typically comes back, those memories typically come back, but the more ECT treatment someone has, the less likely those memories are to come back. So it's an option, but again, it's for severe treatment-resistant depression when we're talking about it. Another new treatment for depression is what we call transcranial magnetic stimulation, or TMS. And TMS works by using magnets to generate precise electromagnetic pulses within the brain. And it's thought to be another option for medication-resistant depression. It's not as effective as ECT though, but it does have fewer side effects. Typically, the side effects for ECT are just occasional headaches. We don't get the memory loss. But again, it's not as effective. And this is a new treatment. We don't have a lot of research on it just yet on how long lasting the effects are and what the long-term effects of it will be. So I have a couple of pictures of animated versions of these. But questions so far about ECT or TMS? Have any of you had experience or like heard about ECT, pop culture, TikTok, movies, anything? No? Anyone seen the movie One Flew Over the Cuckoo's Nest? It's in that movie towards the end. ECT has a really negative reputation as a whole. Why might you think that's the case, that ECT has a negative reputation? For the folks who've seen One Flew Over the Cuckoo's Nest.
It's like still on, like,
Mm-hmm. They're in a mental hospital, like a mandated hospital where you're not allowed to leave. And also in that movie, it's been a very long time since I've seen it. he has long-lasting effects from the treatment where he essentially becomes vegetative. He is like a shell of a human, which is not the case for ECT. ECT doesn't create someone to become like just morose in their approach to the world. They are still them. We're just decreasing that depressive episode. So ECT looks a little bit like this. You have the mouth guard. Again, those paddles are right on the temples, and they're inducing just very short electrical bursts to induce a temporary seizure. And when I say temporary, it's like a few seconds long of a seizure. It's not very long, and they're monitored the whole time under light sedation. TMS, this isn't the best picture, but it's kind of hard to describe. It's like this little, like, looks like the size of a football paddle that's attached to a stick that they hold onto the side of your head. And again, it's just it's got an electromagnetic coil and it's just shooting precise electro currents into the brain. And we don't really know why ECT works, and we're still trying to figure out what TMS is and how it works as well. So these are more of the biological treatments for depression and depression and bipolar related disorder. We also have psychosocial treatments. Any guesses what the most common psychosocial treatment for depression would be based off of what we know about the causes of depression? I mentioned his name and his theory before. Who's responsible for the cognitive triad? Well, let me backtrack. The cognitive triad implies that there is a cognitive component to depression. So what type of therapy might be helpful? Cognitive behavioral therapy. It is the best evidence-based treatment for depression. And it works by addressing the errors in thinking, those cognitive errors, those attributions, those cognitive beliefs that someone holds that is making their depression symptoms maintained or increased in intensity. Cognitive behavioral therapy works by looking at the ways that our thoughts influence our emotions and also influence our behaviors, creating this dynamic where we can look at the interconnections between these to implement change. If we can change the way we think about something, we can change the way we feel and change the way we behave. If we change the way we behave, we can change how we think and how we feel. Change how we feel, we can change how we behave and how we think. Creating all of these mechanisms for treatment. There are these behavioral components with depression from a cognitive behavioral perspective. One of them is the process that we describe as acting as if. This is a true subset or treatment option from cognitive behavioral or CBT therapy, where you ask the person to act as if they do not have the diagnosis. Act as though you do not have depression. What would you do? Would you leave your room? Would you go to class? Would you go out with your friends? Do that and see how you feel. Staying in your room makes you feel this way. What if we change and we act as if it wasn't there? Let's see if that changes anything. It helps to sort of rewire the connection between cognition, behavior, and emotion. Another type of therapy that is helpful for depression is what we call interpersonal therapy or psychotherapy, IPT, interpersonal psychotherapy. IPT works very specifically on improving the problematic relationships in someone's life, which is really helpful because a lot of times folks talk about their depression causing problems in their relationships. Like, my friends don't want to be around me because I'm depressed. My partner says that I'm a terrible partner to be in, and I'm not a good parent because I'm experiencing these depressive episodes and I'm not getting out of bed. IPT works to focus on those relationships and improving the supports that come with them to decrease the symptoms of depression. Because remember, social support is a key component to depression. When we have a lack of social support, treatment takes longer. When we have more support, we are able to sustain our treatment goals or our treatment progress much longer. So IPT works by focusing on that social support. Just as we mentioned before, psychosocial treatments for depression have a much longer lasting effect compared to medications. We see that therapy takes longer to make progress, but the results last much longer, which is why a lot of people are diagnosed or not diagnosed, treated with both at the start, with the goal for a lot of folks that they can taper off the medication, stop taking the medication because they have learned the skills cognitively to make differences. It's not true for everyone, but it is the goal for a lot of folks. In terms of our psychosocial treatments for bipolar related disorders, we do see that they can be helpful in managing the problems that are associated with bipolar related disorders. So we might use IPT to manage relationship difficulties. We might use CBT to address problematic behaviors in the workplace or behavioral therapy specifically. Like, how can we change your behaviors that are associated with this? Maybe how can we address the risk-taking behaviors that you engage in when you're in a manic episode? Family therapy can also be really helpful for bipolar-related disorders in addressing some of the problematic relationships that occur with this disorder. So how do we support someone when they're in a manic episode and in a depressive episode without feeding into the episode? How can we be on the lookout for symptoms for this person when they might not have the awareness to be able to do that? Family therapy can be really helpful in that regard, but it also really depends on how close the person is with their family and their living environment. If we're talking about family therapy for a family that lives 2 hours apart from one another, probably not helpful. But if you're talking about family therapy for someone who lives at home with the family or lives in the same town and they see each other frequently, family therapy might be a good option. But across the board, medication is still the first line of treatment for bipolar related disorder, lithium specifically. First line of defense to get both the mania and the major depressive episodes into a more managed, regulated level. And then maybe adding in some psychosocial treatments. So I've got a little activity for y'all. Over the last year, the prevalence rates that we have for both major depressive disorder and bipolar disorder were the highest for young adults, so 18 to 29 years old, compared to all other age groups. We are seeing an increase in these diagnoses for that age group. Based off of that statistic, I want you to break up into your groups and come up with what you think is the most important thing for young adults to know about major depressive disorder and bipolar disorder to be on the lookout for. What do they need to know? Whether that's risk factors, protective factors, just like things to be on the lookout of. Come up with a list of 4 to 6 things in your groups, and then we'll come back together. How many of y'all come up with so far in your groups? 4? 1? 2? How many of y'all come up with? Couple? Okay, keep going for just a little bit longer, then we'll come back together.
It's gonna get it.
All right. Let's go over and see what some of the things y'all came up with. How about you over there in the group? What's one of the things you came up with?
Not just normal that that's happening.
So just like normalizing, this is no longer within what we would expect for someone. Like, yes, you're in school and you're stressed, and yeah, this is beyond that. So normalizing that. Nice. What about this group over here beside y'all? What was one that you came up with? Mhm. Yeah, so just be on the lookout for yourself. If you have a family member with one of these, be aware. And what might you tell them to look out for in that regard?
Think it's more like symptoms, like
Mm.
more like low line thing, because if you don't think you have it, it's just gonna be like the lower things that add up over time.
Yeah.
Like expose the depressive disorder.
Yeah, it's a great example for everyone in that circumstance. If you're talking about a family or genetic component risk factor, one thing to keep in mind is that every person's diagnosis is going to look different. So there can sometimes be this idea of like, well, I don't have this exact symptom that my family member has, so I can't have it. Diagnoses look different across people. So normalizing that of saying like, yeah, it can look different and still meet diagnostic threshold. Yeah, great example. How about group in the middle here? What's one that y'all came up with? Mm, nice. Nice. So looking for the risk factors of like, hey, if you're seeing these things occurring together, maybe we should start being aware of it, asking for help. So similar to what the first group was saying of like, let's keep this on our radar, let's normalize that these things happen. And if they're occurring at the same time, we should be a little bit more concerned. Were there any strings of symptoms together that stood out to y'all? It was like, be especially aware of these ones. It's okay if the answer is no. Mm, yeah. Mm-hmm.
Just going around.
Yeah. Yeah, so looking at some of those symptoms of mania being strung together. Are you engaging in risky sexual behavior? Are you impulsively spending money? Are you making decisions without regard for the consequences to your life? Are you sleeping a lot less, eating a lot less? If we're seeing all of these things together, like we need to be monitoring what's going on. Nice. All right. How about your group? What was one that y'all came up with? Mm. Yeah, it doesn't have to be this big thing where it's like, oh, I'm going to the psychiatric hospital to get help. You can go see your PCP, go see your general practitioner, get started, get some resources, see if they can help you first, and that's okay. Normalizing that seeking help is great. One that didn't come up that I think is important to talk about in the context of this is how helpful it is to normalize just going to therapy. Therapy doesn't mean that something is wrong. Sometimes therapy is just our way to be the best versions of ourselves possible and getting support in doing that before a diagnosis is ever given. It can be very helpful. It's my public service announcement for the day. Questions about depression and bipolar related disorder before we jump into the really heavy content around suicide? Yeah.
You think that also, I'm like writing a paper on this, so foster kids don't have a lot of support. They do have a lot of like developmental issues, and a lot of that is like behavioral related. And a lot of it has like, a lot of them have like signs of depression, but they don't get help, so it's more longer lasting, like affects their adult life. Not because of support, even because they don't really have a lot of support.
It could be one component. I love that you're writing a paper on this. This is a fantastic topic. There are a lot of factors that can play into that depending on the child. Because if they're going from foster placement to foster placement, the symptoms may be getting lost through the cracks because no one is with the child long enough to notice them. It could be the lack of support for the same reason. It could also be a trauma component. And if that's the case, then would we diagnose depression or would it be more of a trauma diagnosis? Like there's so many factors, but social support could be one component. Yeah. Great topic. Any other questions? Okay. We're going to talk about suicide for a little bit and talk about some resources and what this looks like. So take care of yourselves. If you need to step out, if you need to just zone out for a little bit, go ahead and do that. But to ground ourselves around suicide discussions, I want to reiterate how important language is on our topic of suicide. As a society in the United States, there have been people who say, and even in our like news outlets for a long time, people would say someone committed suicide. When we use the language committed, what's the first thing that comes to mind? Someone committed a crime. Suicide is not a crime. We don't say that someone committed suicide because they have not done a crime. We also don't say that someone completed suicide. For a lot of folks, the language completed implies a successful, happy ending. And for families that have had someone who have died by suicide, that language can reactivate a lot of hurt for them. So when we talk about suicide, the language that I want you all to use, hopefully moving forward, is that someone died by suicide, or you can use suicide as a verb, someone suicided, or someone ended their life by suicide. It's talking about the behavior as reporting the news. They died by suicide, they suicided, they lost their life, or they died by suicide. It's no longer implying any connotation, positive or negative, or implying crime. It's just reporting the news around suicide, as we say it. This is something that you're going to hear a lot from folks that they don't know the impact of this language. You could use it as an education opportunity if you want. When we talk about suicide as well, there are multiple indices of suicide or different levels of suicidal thoughts and behaviors. One of the first things that people think about with regard to suicide is what we call suicidal ideation. These are the thoughts that someone has about suicide, the serious consideration of suicide specifically. So a suicidal thought is the serious consideration of suicide. Not just Professor Arkfeld was talking about suicide, so I'm thinking about suicide, I have suicidal ideation. It's thinking about suicide as a serious option for yourself. Another degree beyond suicidal ideation is creating a plan for suicide, which is when someone has a detailed method or detailed plan for ending their life by suicide. They know what they're going to do. They know when they're going to do it. That's a plan. Related to a suicide plan is what we call a method or a means or capability, which is, does someone have access to the ability to enact their plan? Whatever the plan may be, do we know if they have access to the mechanisms that would be necessary? So as a clinician, when I ask about suicide means, if a client tells me I am going to die by taking a lot of pills, my question would be, where are your pills? How many do you have? What are they? I'm accessing means. I'm trying to get what the risk is based off of the availability. So that's what we consider to be the means of a suicide attempt. There's also a related component to a suicide plan that we call arrangements. Arrangements directly relates to the things that people are doing in advance of a suicide attempt. Saying goodbye to loved ones, writing a letter, giving things away, things of value. That's what we call making arrangements. And then our suicide attempts are the acts that someone engages in that are non-fatal. So a suicide attempt was that the plan was enacted, but the individual did not die by suicide. Yes. No, that's a great question. So the question was, for suicidal ideation, is there a specific amount of time that someone has to be experiencing the thought for it to be considered ideation? And the answer to that is no. Usually it is just the presence of the thought, even once indicates, okay, this person has had at least one suicidal thought. There are different types of suicidal ideations, though. We have what's considered more active suicidal ideation and what's more passive suicidal ideation. Active suicidal ideation is considered to be more risky because these are the thoughts of, I want to kill myself. I need to stop living. Where passive suicidal ideation is more indirect. It's more like, if I wasn't here, like things would be a lot easier. If I just didn't have to deal with this anymore, it would be so much better for everyone. That's more of like that passive. Active is traditionally labeled as the more risky because it is more explicit. But it's important to keep in mind both as a risk. Yeah, great question. Other questions so far? Depends on the person. A lot of folks have both simultaneously, and they can both be spur of the moment, so it's hard to say. A lot of times, folks who have more passive say that that is just constant, whereas the active comes more in waves. But again, it varies from person to person. Yeah, great question. What other questions? One of the reasons why we talk about suicide is because it is so common in our environment. In the United States alone, suicide is considered the 10th leading cause of death across all age groups. So it's pretty common. And again, within the United States alone, frequency of suicide is maybe higher than you realize. Within 1 year, it's estimated that 12.8 million people will seriously consider suicide. These statistics are from 2023, reported in 2025, because we have to do historic data. So these are the stats for 2023 that were just published this year. 12.8 million people will seriously think about and consider suicide. Of those, 3.7 million will go on to develop a plan. And among those, roughly half will go on to attempt suicide. In 1 year, it is estimated that nearly 50,000 people die by suicide in the United States. If you do the math, it's about 1 death every 11 minutes. More people than you realize think about suicide. People in your life, people in your classes, people that you love, people that you know, people that you don't know. Think about these things to some degree. Some would say that all of us at some point in our life will think about suicide to some degree. Whether that is just a passive, I wish I didn't have to deal with this anymore. I wish that I was gone. To more active thoughts. Some would say that all of us at some point in our life will experience that. It is much more common than people realize, even though it's not talked about. There's a lot of taboo around suicide, talking about it, which is why I make it a point to talk about it in this class. We talk about it especially in regards to depression and bipolar related disorder because it's common. Suicidal thoughts are a symptom of a major depressive episode. And folks who have bipolar related disorders are likely to attempt suicide when they're in a manic episode. So it happens a lot related to these diagnoses, but it's not exclusive to these diagnoses. Across genders, actually it's sexes, I apologize, I didn't update my slide. Males are more likely to die by suicide than females. I also forgot to update this slide apparently because I used outdated language. The language around completing suicide has only been updated in the last 5 years. So it's a relatively new change, but males are more likely than females to die by suicide. Females are more likely than males to attempt suicide. The reason for this difference historically is that males are more likely to choose lethal means compared to females, which is why the attempt is more likely to result in death for males compared to females. But this disparity is variable depending on your culture. For example, suicide in China is more common amongst females dying by suicide specifically, because it is informed by our society. In China specifically, suicide is seen as an honorable solution to problems, which is why we see it being more common among females. Among the risk factors for suicide, there are many. I'm going to talk through just a few. The number one risk factor for any suicide attempt is previous suicidal behavior. So a past suicide attempt is the strongest predictor of a future suicide attempt. And the research supports this because we have people who go on to attempt multiple times. So past suicidal attempt is the strongest predictor of a future suicide attempt. Having someone in your family who has died by suicide is also a risk factor. Part of that can be the genetic vulnerability of the diagnoses that underlie that person's mental health, but it can also be access to conversations about it, access to means and what that means, as well as how the family frames it. Having a mental disorder diagnosed is also a risk factor. Having any mental disorder diagnosis increases someone's risk for suicide by 8. 8 times more likely for any diagnosis. The more diagnoses you have, the more the risk increases. Alcohol use and misuse up to abuse is also a risk factor, particularly during the attempt or leading up to the attempt. It tends to be a risk factor because alcohol affects our inhibition, our lack or our desire to stop a behavior is limited. And stressful life events, especially experiences of humiliation, can be associated with suicide attempt, especially if that humiliation leads to a sense of hopelessness. And for folks who have active suicidal thoughts, having a plan and access to the lethal means to enact that plan is also a risk factor. And when we're talking about the risk factors here, essentially the more of these you have, the more concern other people around them are going to have, especially if you're talking with a clinician. It's like an additive effect. We've talked a little bit about in here so far that there's this big taboo around talking about suicide. And that is because of this idea in our society that talking about suicide is contagious. If you talk about suicide, more people are going to die by suicide. In reality, suicide is not contagious to people who are not already at risk. Rather, individuals who are already seriously considering suicide may be at higher risk for attempting suicide after hearing about another attempt. So simply asking someone if they have thoughts of suicide does not put them at risk. What does put someone at risk is individuals who are already experiencing thoughts of suicide, hearing about attempts, the means by which they occurred will increase that risk. But for folks who are not at risk for suicide, they are not experiencing thoughts of suicide, simply asking them is not going to make them at risk. Media plays a big factor in suicide contagion, which is what we call like this contagious aspect of suicide. And media works to worsen the risk of suicide by sensationalizing or romanticizing suicide. So talking about it as something that the person had to do and it was a great thing that they did. Romanticizing it, it's going to solve all of the problems in that person's family. That's romanticizing or sensationalizing it. Also, the more specific media outlets are in describing the lethal methods of killing oneself, the higher the risk for those who are already at risk. If you end up taking intro to counseling with me next semester, I will teach you all how to do a suicide assessment by becoming comfortable asking someone, are you experiencing any current thoughts of suicide? Exactly like that. I will teach you all how to do it. Suicide prevention is really important. If you think that someone is at risk, talk to them, ask them, are you having thoughts of suicide? Get them some support. Ask them if they need support. What is that support? And make sure that they enact it. Talking to someone else about suicide is not going to place them at risk. It's not going to plant the idea of suicide, especially for those who are already experiencing suicide. But the ramifications for not asking someone are tremendous. It is better to ask and make sure that that person has support than it is to not. I have a video that I'm going to post on Canvas that walks through, it's called Surviving the Loss. It's individuals who've lost family members and loved ones by suicide and what the lasting effect of that has been for them. I can't show it in class because I'm recording this and I'm going to post it to YouTube. And if I show the video, my video will get copyrighted and they'll take it down. So, important resources. I want all of you to take a picture of this screen. These are resources that you can access at any time if you have thoughts of suicide or if someone you know or love has thoughts of suicide. Keep this on your phone, send it to whoever you need to. On campus, you can go to the Wellness Center. You can ask them for support. If you are calling or needing someone at 2 o'clock in the morning, you can access those resources. The National Suicide Prevention Line Lifeline, you can dial 988 on your phone and you can talk to someone immediately. Fun fact, if you are from Iowa and you dial 988, the chances that you are going to be speaking with someone who is in the Midwest are extremely high. Your call is most likely to get routed to the Boys Town National Hotline in Omaha, Nebraska. They are the #1 provider for the National Suicide Prevention Line Lifeline. They service all of the Midwest and they get all of the overflow calls from other countries. I know that because I worked for them for 3 years. You can also text the crisis line, CTL, by texting home to 741-741. Or if you know someone who's not comfortable talking with the National Suicide Prevention Line, they want to talk with someone because they maybe identify with a different gender or sexual orientation and they want support in regards to that, the Trevor Project is an amazing resource. You can text and call. Had we had time, I was going to have all of you come up with your own resource, but I don't have time because we are out of time. Our exam is on Tuesday. Do you want me to just like rapid fire tell you things to like study? Is that okay? I know I'm keeping you past time, so I apologize in advance. All right, so overview of the exam. There are no true false. Thank you all for telling me that it was terrible. Just by like grading it, I was like, oh, this was not good for any of us. I hate seeing these scores. You all hate seeing these scores, so I'm happy to get rid of them. So it's 32 multiple choice. So that'll be worth 2 points each. So it's 64 points in multiple choice questions, and then 11 points in short answer questions. For the short answer, yes. No, you're good. For 3 short answer questions in total worth 11 points. So you will, just like the last exam, you'll have your choice of 2 short answer questions to answer for each chapter. So 2 for chapter 5, 2 for chapter 6, 2 for chapter 7. If you care, chapter 5 is worth 4 points, chapter 6 is worth 4, and chapter 7 is worth 3. Not that that matters right now, but you'll have your choice of 2. So you can choose the one that you know better and answer it that way. A couple of things to keep in mind while you're studying. Know the essential feature of each diagnosis that we've covered. So that primary required criterion. Because they are unique to each diagnosis. So sometimes it helps to just map them out. I'm sorry, do y'all have practice? Oh my God. Okay, I'll go fast. This is also going to be recorded and posted so you can access it. So leave if you have to get to practice. I don't want you to get in trouble. Yes, please, please, please. Yeah, just like scoot to the very end of the recording and listen to that. Sorry, y'all. I know this took a long time. In addition to knowing the essential features of the diagnosis, also know any of the unique symptoms. So keep in mind the differences between an obsession and a compulsion, for example. Know the difference between fear, panic, and anxiety. Know the difference between mania and hypomania. And the differences between depersonalization and derealization. And know what fugue is. So like know some of those unique symptoms. Do you need me to repeat any of those? All of them? Yeah. Obsessions, compulsions, fear, anxiety, panic, mania, hypomania, depersonalization, derealization, fugue. Those were the ones that I pulled like right away as like those unique symptoms. Think of like those types, know what they are, definitions, maybe a description or an example of them would be helpful. Know what diagnoses they're associated with as well. That's going to be helpful. When you are going through and you're doing those essential features of the diagnoses, pay attention to the similarities and differences. I call these your differential diagnoses. So know the difference between illness anxiety disorder and somatic symptom disorder. Know the difference between bipolar 1, bipolar 2, cyclothymia. Know the difference between major depressive disorder and persistent depressive disorder. And know the differences between generalized anxiety, social anxiety, panic, phobia, agoraphobia. Like, know what makes them different from one another. Let me know if you need me to go through that list again. No one shook their head yes. You're going to want to know common treatments. So things like CBT, know which ones that applies to. But if there are unique treatments, also pay attention to that. So like ECT and TMS being associated with depression, lithium being associated with bipolar disorder. You want to know those, have a general idea of what they are, what the difference is between ECT, TMS, that sort of stuff. You also want to pay attention to notable differences in symptoms or diagnoses by age and sex. So, for example, when we were talking about suicide, know the differences between attempts and deaths by suicide as they vary for sex. That males die by suicide more often, females attempt suicide more often, that sort of thing. And then you want to know the theories behind the causes of these diagnoses. So because it's fresh on our mind, I'll use the example of depression. Know like the theory of learned helplessness, the depressive cognitive triad. If we had a notable cause like that, You want to just know what it is. And you want to know what is involved in it. Can I repeat anything?
Could you repeat, like,
Yeah, so illness, anxiety disorder, and somatic symptom disorder, you want to know how they are different from one another. You want to be able to differentiate them. Would it help for me to talk about how they are different again?
No, that's.
Okay. Yeah, no, I appreciate you asking. Any other questions? I learned my lesson on the last exam. Still study, you still have to study hard. The exams are still hard. I just learned no more true false. And be a little bit kinder. Have a great weekend, everyone, and I will see you all on Tuesday.